model for and behavioral choice model for continuing to study addiction. So from there, he went to Brown University for a clinical internship, and he stayed there as a postdoctoral fellow in a highly regarded Center for Alcohol and Addiction Studies. And it was there that he hooked up with James McKillop and started doing really transformative research on hypothetical purchase tasks. Again, a behavioral economic model for examining behavioral choice and risk in the area of addictions. And it's work that continues to this day, and work that certainly we lean on a lot and have integrated into much of the work we're doing here in the Vermont Center on Behavior and Health. I already mentioned that Jim is an endowed professor. He has more than 150 publications. He's a fellow in 2 APA divisions. He's received national awards for his research through the NIH and also through AABT. He's a standing member of NIH Studies Section, associate editor on several journals. He's just really had a very distinguished career. And so I am really thankful that Jim took time out today to join us virtually. So Jim, please take it from here. Oh, I'm sorry, we have some housekeeping first about how the virtual lecture is going to proceed. So Nicole, can you take us through the housekeeping? Then we'll turn it over to Jim.
Sure, I can do that. Thanks, Steve. So I just wanted to let everyone know that Dr. Murphy is going to present for about 45 to 50 minutes, and then we'll break for some Q&A. Our chat function is live for everyone, so you can introduce yourselves or have some side conversations as they're relevant. We'd ask that you please share any questions that you'd like to have answered by Dr. Murphy in the Q&A box and not in the chat box. That's where we'll be monitoring those questions. The lecture is being recorded, and we will post it to our website for on-demand viewing afterwards. If you are a physician and are seeking CME credits, those credits are only available if you attend our lecture series when it's live. And if you'd like to stay informed about our future lectures, you can join our mailing list or follow us on one of our 3 social media channels, which are listed below. And with that, we will turn it over to Jim.
Awesome. Thank you so much, Nicole and Steve. Let me share my screen here. And let's see. Here we go. All right. So it is a real honor to be here with you all today. I wish I could be there in person. I tried to get into the spirit of being in Vermont by wearing a long sleeve shirt and long pants for the first time in about 6 months, which when you're in Memphis during a pandemic, there's no need for either. So today I am in the Vermont spirit. It is a real honor to be here with this distinguished group that has been a huge influence on the addiction field generally, but in particular on my work. I don't want to run out of time for acknowledgements at the end, so I want to start by acknowledging my funding sources, in particular NIAAA, but also a number of incredible collaborators and students. Too many to name, although I will name Dr. Peck, who is part of your group and started out back in the Habit Lab about a decade ago as an all-star undergrad, and was who reached out to me with this invitation. So it is, I wish, again, Kelly, I could be there in person, but good to see you. And again, want to express gratitude for all of the incredible students and collaborators that have helped with this work, as well as NIAAA. So I think it's important now to start any talk on addiction by acknowledging that we are in probably the greatest addiction epidemic that the world has ever seen in terms of deaths from overdose over the last decade in the US. So you could see here just staggering increases overall in deaths of despair, which include suicide, alcohol, and drugs, but in particular, overdoses related to drugs and alcohol have skyrocketed. These data show up through 2017, but early indications are that those numbers continue to increase, especially with the pandemic. And I want to say in particular to all of the students and trainees and early career faculty members out there, this is a tremendously difficult time with the pandemic. It's much harder on early career folks and students than it is on mid and senior career people. But it is also important to keep in mind that what you're learning and what you're doing has never been more essential to society. So I know these are tough times for everybody, but I think this really drives home the value of what we're doing and our importance, our increasing importance to society. So I will talk about behavioral economic models of addiction. And these are sort of, choice-based models where behavior is allocated to an activity based on the cost-benefit ratio of that activity. And so as applied to drug use, this suggests that drug use is very predictable based on the price of the drug and the availability of the drug, the availability of alternative ways of experiencing reward, and also the delay of both the drug reward and the alternative reward, right? And the longer a reward is delayed, the greater it loses value. So drug use is predicted to be high in situations where drugs are relatively cheap, easily available, and there are few alternatives. And so addiction is a sort of a state where the reinforcing value of drugs is greater than the reinforcing value of alternatives. And that's called a reinforcer pathology, just to highlight the fact that this is in some ways a typical behavioral process that has gone awry because drugs are such potent reinforcers. They tend to generate immediate reward, and they tend to have pernicious effects on the availability of alternatives, which creates this vicious cycle where greater drug use leads to lower levels of alternatives, which leads to greater relative value for drugs. So this is a conceptual model that has guided a lot of the work that I'll discuss today. And this has been elaborated by Warren Bickel and others in the reinforcer pathology model. And this is a nice figure that explains how even sometimes, so the red represents the value of drug rewards, and the blue represents the value of alternatives, things like school or work or exercise. And then you have time represented on the x-axis. And as you could see, in the moment, drug rewards have a very high value that might exceed that of most alternatives. If, on the other hand, you shift your temporal perspective to a more molar or extended temporal perspective, patterns of drug use over time tend to result in sort of diminishing value, right? There's a lot of negative consequences, there's health effects, there's tolerance. Conversely, patterns of many alternatives, right? So developing an exercise habit, forging new social connections, learning new hobbies, completing an education, all of those things tend to accrue positive value over time, right? And the reinforcer pathology element is that choices are overwhelmingly driven by these sort of what is going to be the next best thing versus what will be the best thing over time, right? And so from the perspective of treatment and prevention, we want to encourage a more molar time frame of decision making, and we also, to the extent possible, want to increase the potency of drug-free rewards. From an assessment perspective, which is where I'll start this talk, we also want to try to measure this process. So that leads us to different approaches that we and others have developed to try to measure these constructs, right? And so there's three general constructs that are associated with risk from this perspective. So one is reinforcing efficacy. So how much do you want or value a drug? And I'll talk about measures of that. The second is measures of substance-free reward, right? And then the third is measures of intertemporal choice, or the extent to which you value immediate versus delayed rewards. So these are the three key measurement domains. And one thing I appreciate about this perspective is that all of these can be measured in animal laboratory studies and human clinical studies. And there's a really nice translation across those two paradigms. and which leads to nice sort of scientific consilience where we could really learn from animal models, apply that in human models, and have a more consilient science of addiction and prevention and recovery. So the hypothetical alcohol purchase task is also known as a demand curve measure, and this was derived from basic animal laboratory psychopharmacology research where in animal models, animals had access to drugs at various response costs. And in the original animal models, the response cost involved how many times would you press a lever in order to get a dose of the drug. And this was mostly used to determine the abuse liability of different drugs, with drugs that generated large amounts of behavioral output having high abuse liability. And so I was exposed to this in graduate school and thought this would also be a great paradigm to quantify how much people really want alcohol and drug rewards, right? In this society, money is a common metric of value, and how you allocate your money is an indicator of your value. And this was based on work that Rudy Vucinic and Jaylee Tucker were doing at the time in the context of recovery. And they were looking at actual patterns of financial expenditures towards alcohol versus other pro-social activities and savings. And this purchase task was a way that I thought of to do this in a way that's brief and efficient to quantify how much you value alcohol specifically. And so we developed this initially with young adults. And so young adults typically drink in social bar or party settings. And so we provided a scenario that approximated that typical drinking context, which here you could see is you're at a bar, you're there for 5 hours, and you could purchase drinks across a variety of prices. And what we see is that you could generate a number of different indices of value here, right? So the most intuitive and one of the most predictive indices is called intensity, which is simply how much would you drink if price was zero. So if you went somewhere and drinks were free, how many drinks would you have? And that's represented here. And there's a reason that's predictive of problems, and that's that many of the problems people experience from alcohol are due from really high episodic consumption, right? So there's other measures. So probably the next most predictive measure is called OMAX, which you get from looking at expenditures. So if you multiply the number of drinks somebody would have times the price. So if somebody said they would have 10 drinks, if drinks were $5, that would be a $50 expenditure, right? And so that might be somebody's OMAX value is $50, right? So OMAX is sort of like, how much would you spend overall? What's the maximum expenditure? That's also extremely predictive of a lot of different clinical outcomes. And this is a measure that can be administered in 2 or 3 minutes. It's hypothetical, but there have been nice studies by Michael Amlong, James McKillop, and others showing that these hypothetical choices correlate strongly with actual drink purchase choices, right? The benefit of the hypothetical models is that A, they're convenient, but B, it's impractical and unethical to model high-level consumption in laboratory paradigms with humans, right? You could get humans to purchase and consume, maybe 3 or 4 drinks in a lab setting. Beyond that, there are ethical proscriptions against that. So to really model the kind of consumption that we need to clinically, it's important to use this hypothetical approach, but it's also important that it's been determined that this corresponds well with actual choices and that it is stable over time. So over the last decade or so, a number of groups have shown that elevated demand is associated with a number of different indices of alcohol and drug use severity, right? And this is one example. This is a study that we did with Nicolas Berthollet and a number of his colleagues in Switzerland, where the demand curve mapped on really nicely with the various levels of alcohol use severity in a large population sample of Swiss men, right? So you could see those with severe AUD had the highest demand curve, right? Their intensity was almost 15 drinks if they were free. All of the different groups reduced drinking as price went up. And those without alcohol use disorder, but who were still drinkers, had the lowest curve. So this maps on well. This was a study, Jenny Teeters, who is on the faculty at Western Kentucky, was a doctoral student in my lab, did a really nice study with drinking and driving, where she showed that even after controlling for young adults' level of weekly drinking, their demand uniquely predicted their recent experiences with drinking and driving. And so this is the demand curve for young adults who reported recent drinking and driving. This is the curve for those who did not. So the folks who sort of have more demand, they want alcohol more as reflected in their expenditures and the extent to which their consumption is price sensitive, are more likely to drink and drive. So nice correspondence with real world choice. And another important discovery is that your demand for alcohol is also very much influenced by what you have going on the next day, right? And so this has enormous prevention implications. So if you take a group of college student heavy drinkers and you tell them to imagine that they're in a drinking scenario where they have no class, no work the next day, this is what you get. You get really high consumption, right? If you tell them they have class the next morning, but the instructor does not take attendance, you get a huge reduction, but still really high drinking levels. If you tell them to instead imagine that they have a class the next morning with a test that will amount to 20% or 25% of their grade for the semester, you get a additional incremental significant reduction in drinking, right? So drinking is very sensitive to both price, but also context. Interestingly, individuals have differential sensitivity to context, right? And this one factor with humans, so here we've plotted the percent reduction in demand. So here, higher numbers are greater reduction, right? So this group, the black squares, are folks with no family history of alcohol use. These are all heavy drinkers. This group has a positive family history of alcohol use. Those with no family history reduced their drinking when they had a next day test by over 60%. Those with a positive family history reduced their drinking, but by substantially less than those without a positive family history. So this suggests, and interestingly, family history was not related to overall demand. So this is this really specific way of capturing maybe a lack of sensitivity to context in drinking decisions. And there is a paper published in Science recently that found in animal models that there are genetic differences in sensitivity to alternative rewards that are linked with risk for alcohol self-administration. So again, nice consilience across animal and human studies and support for the idea that context matters, but there's individual differences in sensitivity to context. This is another study. Keenan Joyner is a doctoral student at Florida State, was an undergrad in the Habit Lab when he was at Memphis. And he did a similar paradigm where we call this, when your purchases with class the next day are called high opportunity cost demand. No class is low opportunity cost demand, right? And so similarly, this is a different sample. We found much greater drinking when there's no class the next day. But what he found was that drinking when you have class the next day is uniquely associated with recent weekday drinking and also with a set of more severe and less frequent alcohol problem items, including alcohol dependence symptoms, right? So this measure also tends to be sensitive to very specific indicators of problematic drinking. And Samuel Acuff, who is a current graduate student in my lab, who's supported by NIAAA F31, did a really nice meta-analysis recently where he showed that although demand can be the stable individual difference measure, it is also very sensitive to state influences, right? And this is a meta-analysis that shows that across a number of different studies, many of these done by James McKillop and Michael Amlung, Q exposure increases demand, negative affect or stress increases demand. Conversely, Lara Ray and James Bukowski have done some nice studies showing that naltrexone reduces demand, And I'll talk about studies we've done in a minute that shows that behavioral therapies also reduce demand. Opportunity cost is the next day responsibility study. So demand is sort of acutely sensitive to contextual influences as well. All right, so the next set of measures look at how much activity and enjoyment you garner from alcohol and drug-related activities relative to alcohol-free activities, right? And this was a measure originally developed by Chris Correa and Kate Carey, where they took a reinforcement survey schedule, which had been used for the treatment of depression and assessment of depression, and modified it to separate activities that were done in the context of drinking or drug use versus those without, and enjoyment, right? And if you multiply frequency by enjoyment, you get a proxy for reinforcement, and that allows you to generate a ratio value, the substance-related reinforcement divided by total reinforcement, and you could see this quantifies kind of the relative value of drugs in somebody's reinforcement portfolio, so to speak, right? You could have two people that drink the same amount, right, per week, but one person, substance-related reinforcement accounts for a small part of that portfolio. For this other person, drinking and drug use are sort of just about their only way of experiencing reward, right? And so what we would predict, what this theory would predict, is that these two people would look very different in terms of their clinical outcomes. And this measure has been shown to be both stable over time and also associated with a number of indices of alcohol problems. This is a recent structural equation modeling paper that Sam Acuff and Catherine Soltis, Ashley Denhart, and others did, where both alcohol demand and the proportionate reinforcement measure were associated with alcohol problems and consumption. They both were significant even in the context of the same model. And a measure of future consequences was also a significant predictor. Interestingly, delayed discounting was not, and we have across the board with young adult populations found much less consistent associations between discounting and substance use than studies with adults have found. So I think discounting is trickier to measure in young adults who have little experience with financial decision making and who may expect significant changes in their financial outlook following graduation or job development. So, but this study suggested that both of these measures are associated with problems, right? The other thing these measures have demonstrated utility for is predicting response to treatment and also changing based on treatment. So this is a study, a brief intervention study, where we had 3 conditions. We had assessment only, we had a motivational interviewing plus a relaxation session, and a motivational interview plus a behavioral economic substance-free activity session, which I'll talk about in a few minutes. And these are heavy drinking college students. And you could see assessment, no significant change in the proportion of activities from substance-related relative to substance-free activities. Both of the active interventions showed significant reductions, and the extent of this reduction predicted change in drinking over time, and also mediated the advantage of these 2 interventions relative to assessment over a 16-month period, right? So this change is critical to the long-term change in drinking, right? Which provides really nice support for the behavioral economic model. And we found similar results with a completely different paradigm. Joanna Buchemi is on the faculty at DePaul, and she and I modified this measure to measure food-related and food-free reinforcement, and found that it similarly predicted weight loss over about a 2-year period in people participating in weight loss interventions, right? So being able to have a greater proportion of your activity from food-free activities was a unique predictor of weight loss. So this idea of thinking about relative value seems to have clinical relevance. And demand curves show the same sort of association. This is the study from Lara Ray's lab, where naltrexone reduces demand. This is a under review study that Catherine Soltis has done in my lab, where the two brief interventions that I mentioned reduce demand from baseline to 1 month, right? And that change in demand from baseline to 1 month predicts drinking over a 16-month follow-up, right? So again, really nice clinical utility. And what's nice about the purchase task is that you could actually administer it immediately after an intervention session. And it goes down immediately after, right? And the extent of that reduction tends to be stable, and it tends to predict outcomes. So there's nice potential for using this as a marker of, did somebody get an adequate dose of intervention, right? And folks, I think in your center and other centers have also found that the purchase task predicts response to contingency management. So there's good, with both young adult and adult samples, good support for the clinical utility of this purchase task. All right, so another, I think, really substantial contribution of behavioral economics and really more generally operant psychology models of addiction is that addiction can very predictably, occurs when there are few alternatives in the environment. And this goes back to, the rat park studies, which had some methodological limitations, but various, iterations of those studies have been replicated with different paradigms, where essentially if you take an animal and put them in a deprived environment like this poor lonely rat here with nothing to do in this operant chamber, they tend to use a lot of drugs. If instead you put them in an enriched environment, a rat park where they have all sorts of things to do, they're less likely to use drugs. This is another study from Miller et al., where just providing access to a running wheel reduced infusions of methamphetamine, right? So this is a pretty robust finding. And I think one of the most practical basic science findings we have in the addiction field that I think has still not been fully implemented in terms of policy and treatment. So I think this leads us to think about, well, what does reward deprivation mean in humans? And I think this is becoming more and more relevant in our society right now, right? So you could think about things like poverty as just an obvious manifestation of reward deprivation. And Adam Leventhal and his group have done really nice work showing that in a large sample of teens in LA, that poverty is associated with drug use, and that association is partially mediated by lower access to substance-free activities, right? So it's intuitive, but again, it hasn't really guided our science as much as more simple kind of disease models have, right? So other things like discrimination, racial trauma, right, which again is sadly sort of ubiquitous in our society right now, those are things that reduce access to reward. Many other environments lack access to social and leisure activities, mental health conditions, people with depression, anxiety, social skill deficits. You could think of those as being ways of just walling off or creating a barrier between the individual and the experience of reward. Medical conditions, pain, transitions, life events. And as I mentioned earlier, there's also this cyclical vicious cycle where the more you use drugs, the less you're able to experience natural reward, right? And of course, there's also what's been described as a loneliness epidemic in our country. This is even before the pandemic, right? So now it's worse. But so many people in the US live alone and have very little social contact. And so that's a huge risk factor for increased desire to use drugs. And so I think the take home from this, and I do appreciate that even among the NIH institutes that used to be very dominated by sort of brain disease models and still are for the most part, but there's definitely an increasing recognition that addiction is also a disease of the environment, right? And that maybe we have more ability to modify those variables than we do these variables, right? We've sort of really tried to modify those biological variables, but short of totally, undermining the brain's motivational system, which is necessary for survival, it's sort of hard to turn off, that potential desire for drugs, right? The cocaine vaccine that was sort of kind of envisioned in the 90s. I think you don't hear as much about that. And so I think increasingly it's incumbent upon us to understand more about how environments confer risk for addiction. So in addition to the deaths of despair and the addiction epidemic, we're now, of course, in a global pandemic. And this is, data suggesting that people are feeling way more isolated or lonely. This is pre-COVID, this is post-COVID, right? Double the percentage of people feeling isolated or lonely. People have reporting too much time on technology, less access to exercise, lots of mental health conditions. And predictably, we have increases. This is just from Florida, but it's the most recent data I could find on overdoses and uses of Narcan. So this is up to this past June. And you could see what looks like a COVID-related spike in overdose. Alcohol consumption seems to be up, right? Not across the board, but overall, or not, there are exceptions, but overall, it seems like people are drinking a lot more. We'll think about what we talked about, the price. You can now, there's apps where you could get, alcohol on your doorstep in 30 minutes, right? And so it's a lot easier to gain access to drugs, whereas it's harder to gain access to many other reinforcers. And Sam, Jay Lee, and I have a paper coming out that looks at sort of a behavioral economic model of COVID-related risk for addiction that goes into this in more detail. I want to also highlight, these are data that Shannon Monat from Syracuse University, really, really compelling data that she just published, looking at the environmental predictors of overdose. And so this is a map of overdose risk in the US. And you could see it's not evenly distributed. There's pockets of risk that are tied to environments. And this is really compelling. This is the percent difference in drug mortality as a function of these risk factors. And you could see a huge increase based on the percentage of people in a given county who are separated or divorced, the percentage of people who are not working, right? Of course, opioid prescribing, so that gets back to the availability of drug rewards, public assistance, four-year college degree attainment, that's a huge predictor as well, right? So again, we could predict these things. And again, the deaths of despair seem to be largely, impacting people without a college degree, right? In this society, having a college degree is probably a proxy for being able to experience a lot of reward in different ways. And so you could see the increase over the last 2 decades is almost all in women and men without college degrees. And there's a lot of other cultural shifts, I think, that have implications for the availability of reward. We can't make causal assumptions from this at all, but over the last 15 years, there's been huge increases in time spent online. There's been huge decreases in time spent in in-person social interactions, again, even before COVID, and in sleep. And this tracks really well with the decrease in happiness. And the things, and these are among teens, that are most correlated with happiness are things like sleep, time spent sleeping, time spent in sports or exercise, and in-person social interaction. And it makes sense if we think from an evolutionary context, right? These are things that humans in their evolutionary environments had to do, right? So until the past few centuries, we essentially had to be together with people working towards goal-directed activities and moving about outside, right? So you could think of that as a natural sort of state, right? And so it would make sense if you didn't do those things, if you were solitary, then you wouldn't survive for very long because humans were not very effective on their own. They really needed to work together for survival. And so when we think about treatments that try to enhance reward, and we think about, well, what sorts of rewards do we want to enhance? I think it's helpful to look at, the data that I just presented, but also to sort of think about, well, what are some of the things that sort of humans have always needed to do to survive? Because those are most likely to be the things that would be the most potentially effective substitutes for drug rewards. And so we're ill-equipped for dealing with abundance, right? With food and drugs, we're more prepared for scarcity. And we really probably need social activity, physical activity, and activities that increase our social status, right? Within our social context. Now the problem, and I think what's often overlooked, especially for young adults, which is when drug and alcohol use starts, is that drug rewards actually facilitate social reward, right? I think we would have a much easier job as prevention and treatment scientists if there wasn't this correlation, this association where drinking and using drugs actually results in social connection. I think that's really, it's not just the substance, it's the fact that the substance enhances social reward that makes this such a challenge, right? Michael Syed has done really nice studies where in placebo-controlled studies where you objectively measure the quality of social interactions, young people who drink alcohol have improved social interactions, meaning more laughter, more conversation, a better time, right? So it's not just an expectancy, it's real. We've done studies that have shown that when young adults who go through our brief intervention protocol, when they reduce their drinking, right, which we see as a really good outcome, their social reinforcement also goes down, and even their substance-free socializing goes down, right? And so this is what we're up against, that oftentimes when people make a positive change in their substance use, it comes at a cost of social reward, right? And I think we assume with older adults and people with more severe addiction that's not the case, but I'm not sure that we really know that, right? I think a lot of times, even folks who might have a more severe addiction might have a couple of really close friends who they're using with who constitute, almost all of their social reward. And so when you're asking them to stop using a drug, you're asking them to forego the drug reward, but also the social reward. And of course, not surprisingly, drinking is much higher among young adults, probably in part because of that social reward. Cannabis use is also much higher among young adults, in particular young adults who don't use college. This is daily cannabis use, and you can see how that's increased over the last decade. All right, so this is a recent study where we really tried to quantify the impact of the social environment on demand, right? And these are folks who have 4 or more friends who report binge drinking. This is their demand. Folks with 2 or more friends who report binge drinking, and folks with 0 friends. And these are all heavy drinkers. The whole sample are heavy drinkers recruited from the community. And what this suggests is that individual valuation of alcohol really has a lot to do with your social network. Demand curves have also are a nice way to model, like, well, what happens if you're in a hypothetical scenario, right? Any Mad Men fans, you could see Don Draper often drinks alone, but he also sometimes drinks with his friends. And this is a study, again, Sam Acuff and Catherine Soltis generated this study. And we asked people how many drinks they would purchase and consume if they were by themselves versus if they were with, I think it was 2 friends, right? And we stipulated that the friends would make the same drinking choices that they would. And you could see that social context, people like drinking alone, but they like drinking with friends a lot more. All right, so more generally, I think it's important for us to think about this reward deprivation, right? And how to measure it, and how we might use this to inform treatment and prevention. And so, one way people have devised to measure how much you respond to drug-free rewards is through these sort of image tasks, where you bring people into a lab, you have them look at a pleasant image like this, and they either make a rating of how pleasant that is, or if they're in an fMRI or an EEG paradigm, you could use, objective sort of brain response. And these studies suggest, this is a study Lydia Mashesha did in my lab, where we took a group of polysubstance users, they were all prescription opiate users, and those who were, versus controls, those who were prescription opiate users reported lower hedonic response to images like this compared to those who were not, right, controlling for demographic variables. And that persisted over a 12-month period, right? And the ratings of the hedonic value of these substance-free images actually predicted change in drinking 12 months later, even after controlling for depression, age, gender, and ethnicity. So this suggests, again, some clinical utility. There's a measure called a reward probability index, which again came from the depression literature, where it looks at more stable predictors of sort of low levels of reward in your environment. So feeling like your behaviors often have negative consequences, you don't have financial resources, you've had bad events that have happened to you. And there's another scale that looks at more kind of hedonic capacity. And Keenan Joyner did a study that showed that those with severe versus no AUD had really marked differences in reward deprivation, right? So here, higher scores equal more reward. And so you can see those with, these were all heavy drinkers, right? So controlling for drinking level, just looking at AUD seems to be really strongly associated with reward deprivation. And we took that same sample and followed over time, and we could see those differences are stable over a 16-month period, right? People with either none or mild AUD have much higher levels of reward. People with moderate to severe AUD, now these folks are in a treatment, so there's some increase over time, and I'll talk about that more in a minute, but you can see a real stable reward deprivation process that's occurring over a 16-month period among young adults. And so I think all of this work suggests that treatments should really focus on enhancing reward. Your center has been at the forefront of this, and there's now a number of other approaches as well that really try to increase reward. And I highlight 12-step interventions there because, the work of John Kelly and Keith Humphreys and others suggests that although the theory behind 12-step doesn't have a lot of sort of scientific support, 12-step interventions are an incredibly effective way of increasing social support, right? And so they're actually increasing reward, and it's that increase in social support that accounts for their benefit, right? So all of these treatments increase reward. And my work and others have tried to do this for people who are not seeking treatment, right? So these young adults who are not going to present for treatment, but who might also have these reward deficits that we just described. And so I'll describe quickly this substance-free activity session, which is a one session. We now have added some booster content where you try to identify an individual's goals and values, the substance-free activities that they enjoy, and you use motivational interviewing to encourage them to engage in those things more. And so you do things like providing feedback on how they spend their time and asking them how that fits with their goals, right? Their current and future value of those activities, and how any change might be more aligned with their goals. We also give them feedback for college students on what they need to do to achieve their goals. When we use this with non-college populations, the feedback is more about activities they could do in their community or other things they could do to increase their positive experiences. Importantly, young adults are often not at all motivated to discuss their drinking, but they are very inclined to want to have a session focused on what they want from life and how they could experience more joy and more reward, right? And, this theory and our research suggests that even if you don't touch drinking, right, if you increase substance-free rewards, that will have an indirect positive effect on drinking. So this is a clinical trial. We published this last year in JCCP, which I referred to earlier, where we had 3 groups. We had assessment only. They're all heavy drinkers. We randomized them to assessment only, the alcohol motivational interviewing plus the behavioral economic SFAS, or alcohol motivational interviewing plus individual relaxation. And then we followed them up over 16 months. We had good follow-up rates. And what we found was that both of the active interventions reduced drinking. This is assessment only over 16 months. You could see some reduction with time, right? They're completing assessments, they're kind of maturing out, but much more precipitous reduction in the BMI plus SFAS and the BMI plus relaxation. This is alcohol problems. You see the same pattern, right? And this pattern of pretty moderate to large effect size reductions that last for 16 months is substantially more potent than you get with just single session motivational interviews. So it really seems like either helping somebody learn how to manage their anxiety or to engage in positive activities, both of those things seem to enhance the effects of brief alcohol intervention. And importantly, this is a paper that is under review right now. Kevin Campbell helped a lot with this paper. If you go back to those two groups, right, the group with high reward at baseline, right, and the group with low reward at baseline, right, and then you look at those folks who got the BMI plus SFAS showed a substantial increase in their rewards from baseline to 1 month, and actually showed greater levels at 16 months, right? So this intervention seems to increase the experience of reward. This group also, the BMI SFAS, of those who were in this low reward group, they had much higher levels of alcohol use disorder, and only those in the BMI plus SFAS showed a reduction in alcohol use disorder symptoms that was also maintained over a 16-month period. So overall, this study provided support for both of the active interventions, but it suggests a possible moderation effect where people who have low levels of reward might, as you might expect, might particularly benefit from an intervention approach that not only motivates them to consider drinking less, but also helps them to identify and engage in meaningful and personally relevant substance-free activities. We've also adapted this approach for adults in alcohol outpatient treatment. This is Lydia Mashesh's F31. She's now on the faculty at Central Florida. And this was just a pilot study where we added the SFAS to a standard AUD intensive outpatient treatment program. And we showed that the SFAS resulted in a significant reduction in this reinforcement ratio. So, both groups were getting really good CBT, so there was no overall really differences in drinking, but the SFAS, which was 1 session plus booster text messages, reduced the proportion of reinforcement related to alcohol and drug use relative to substance-free activities. We're doing a similar study funded by the HEAL Initiative. Karen Delfenko from UT Health Sciences is the PI, where we're using the SFAS plus mindfulness to try to increase compliance with Suboxone treatment among adults in opioid treatment. So again, trying to apply this approach to increase reward, this relatively brief approach across various high-risk populations. All right, so I've talked a lot. I apologize for going through so quickly, and I'm happy to take questions now and also whenever via email. But in general, I think these data provide nice support for a behavioral economic model to understand addiction, right? I think there's a lot of untapped potential to measure risk for substance misuse using these behavioral economic measures. And I think although many treatments kind of indirectly try to increase alternatives, I think we could do a lot more as a field to really hone in on increasing enjoyable substance-free activities as a primary mechanism of sort of psychosocial approaches to addiction treatment. And from a policy level, I'm intrigued by some of the studies out of Iceland, where at a sort of community level, they made a real effort to increase positive activities among youth and found substantial population level reductions in drinking and drug use. So I think there's a lot of potential there. I will stop here for questions. I'm going to put up this slide so you could get your CEs. And I want to thank everybody for your attentive listening, although you could be sleeping and I wouldn't know it. So thank you.
All right, thanks, Jim, for a really outstanding and inspiring presentation. So as Jim mentioned, we have time for questions. So here's one. Can you elaborate on the SFAS sessions? Is it a series of sessions or only one and follow-up? How long is the session and where are they conducted?
Yeah, great question. So in our original studies with college students, it has been one session, but with booster contact. And they were conducted in our lab. These were not treatment-seeking young adults. They were just young adults identified from large screenings who report heavy drinking. And they were conducted in the lab. In our clinical study that I described in the intensive outpatient, we conducted the single session in the clinic, and then we provided booster text message content, which was essentially letting them know about activities in the community that were tailored to their interests, right? And I'll add one more. Catherine Soltis's F31 used a text message-based approach to delivering SFAS. So that's another possible way of doing that. This was with interactive text messaging, where they didn't even have to come in, which is very pandemic friendly.
Excellent. Another question. Your data suggests that alcohol demand is lower when drinking in isolation relative to social settings, yet social isolation is associated with increased drinking overall, COVID, for example. How do you reconcile those effects?
Yeah, that's a great question. And I think there may be sort of between and within subjects effects there that could be sort of confounding. So I think solitary drinking overall across participants, right, as a between subjects factor is associated with drinking severity, right? But in any one instance, when somebody drinks with other people, for the most part, they're more likely to consume more, right? There may also be developmental moderators there and severity moderators, right? But I think that's an important question. And I think certainly solitary drinking is a risk factor globally across people, but it could also be true, and I think it is also true that for many people, if they're in a social context, on any one instance, they're likely to drink more.
Great, thank you. Another question, how predictive are the demand measures in predicting treatment response in older and more chronic SUD populations?
So I think there's been a few studies. I know there was a study where cigarette demand predicted response to CM. That I'm not sure with older chronic samples if there's been studies with alcohol or other drugs at this point, other than the CM for smoking. So that's that would be an important future study to do.
Okay. And now here's a follow-up question to an earlier one. The earlier question was asking you to elaborate on the SFAS sessions. And this follow-up is, what type of community involvement was there? Can you give an example?
Yeah, so that would be, all right, so by community involvement, I'm assuming you're referring to like what sorts of community activities did people commit to, or did we encourage people to engage in, right? And so those would be things like maybe if they indicated that they had a desire to be more involved with their church, we might give them information about how they could do that. If they indicated an interest in volunteering, we would let them know exactly how and where they could get involved with that. So part of this approach involves having your clinicians keep, sort of aware of community opportunities to experience pro-social activities.
Okay, so I don't see any other questions at this time, and we're about out of time. So Jim, I just want to thank you for a really stellar scholarly presentation, but also one very practical and treatment focused. So it's been wonderful.
Awesome. Thank you so much, Steve. And it's a pleasure to be here. And I'm looking forward, I think I'm going to meet with the trainees in a half an hour. Is that right, Nicole?
Yes, that is correct.
Awesome. So I will log back in 30 minutes, and hope you all have a great rest of your day.
Thank you. And thanks to the audience. You've been great as well. Bye-bye.
Bye.